Pneumonia is an acute, according to our textbook, pneumonia is an acute inflammation of the lung parenchyma. It is usually infectious in nature. Exudate inhibits the gas exchange in the alveolar spaces, leading to consolidation, particularly in the dependent spaces. Community-acquired pneumonia, or CAP, is a type of pneumonia that is generally contracted and presents from the community or the general population. A majority of prevalence occurs in the older adult population. It's usually seen just in the adult, or not just, but primarily in the adult population. It's often associated with patients who have other comorbidities, and it is among the top 10 diseases that cause mortality in the aged populations in the United States. Many organisms can cause pneumonia, but Staphylococcus aureus is the most common, followed by Klebsiella, Haemophilus, and Morzella. The typical presentation is a patient with a sudden onset of fever, a productive cough, pleuritic chest pain, chills, malaise, and fatigue. The patients just don't feel well at all. The atypical presentation for atypical community-acquired pneumonia has a more gradual onset. There's a dry cough and a more pronounced constitutional complaints such as headache and sore throat and chills, myalgia. The guidelines that I chose to review are from the American Thoracic Society and the Infectious Disease Society of America. There were 15 co-contributors from these two groups. These guidelines were initially published in 2019, but after the COVID-19 pandemic, it appears they were revised in 2024. These guidelines, however, have a bias for a higher level of care decision making, such as hospitals, but they're also useful for the primary care provider in an outpatient clinic setting. There are 16 recommendations given in the response to 16 PICO questions regarding the inpatient and outpatient diagnosis, treatment, and follow-up for community-acquired pneumonia. In addition to these, they give strength of the body of evidence that help them decide these recommendations. Beginning at the beginning, question 1 asks if it's recommended to check a gram stain and culture for patients in both inpatient and outpatient settings. The recommendation for outpatient treatment is not to do sputum cultures and gram stains due to the likelihood of contamination or poor collection, resulting in the unnecessary treatment of unassociated organisms. There are high-quality studies that support this recommendation. Incidentally, in the acute care situation, depending on the acuity of the patient, they may do these things, especially if intubated or if they're suspecting resistant bugs, but in the outpatient, no. Question number 2. It's similar to the first, but it asks whether blood cultures are recommended. Again, they're not recommended in the outpatient setting for the same reason as the sputum culture, but they are recommended at higher levels of care and acuity beyond the scope of a clinic. Supportive evidence was of very low quality, but the recommendation is still strong. The third one I looked at is question number 4. This next question asks if viral respiratory testing should be done in conjunction with the CAP workup. The recommendations is for concurrent testing, especially if viral illnesses happen to be circulating in the community. If it's respiratory virus time, then they certainly should be tick-informed at the same time. When this study was done or written back in 2019, this was primarily influenza A and B. The updated recommendation is to test for COVID-19 now as well. Another of the questions that resonated with me on the outpatient basis recommends that the use of prognostic tools be included in the decision matrix for deciding to transfer to outpatient to inpatient care. Of the two tools mentioned, the Pneumonia Severity Index, or PSI, and the CURB 65, those were the two. Use of the PSI along with clinical judgment is good evidence-based practice. The PSI is available on MedCalc for free. That's a tool that you plug in the information of your patient, the demographics and stuff like that, some lab work, and it'll tell you whether to treat as an outpatient or definitely send on to an inpatient. Of all these 16, I picked 5 that I wanted to review. The last one that I picked recommends antibiotic therapy, which antibiotics to choose for community-acquired pneumonia. The study or the guidelines actually gave both inpatient and outpatient, both orally for outpatients and intravenous therapy for complicated pneumonias inpatient. Although I'm in a nursing home and there is the ability to give some IV antibiotics, it's almost exclusively still using PO antibiotics, especially in the long-term care patients. Both the inpatient and outpatient regimes were offered, but so I'll focus only on the outpatient oral prescriptions. Options were given for both patients who are otherwise healthy on the left column and without comorbidities, and those with one or more comorbid conditions that may complicate dosing and pharmacokinetics of the preferred drugs. So on the right hand side, you'll see more of an extensive list of drugs, considering that they may have some renal failure or liver problems or diabetes, something that may alter the absorption of these drugs. For those who are sicker, both combination and monotherapies are recommended, so there's a choice. And the body of evidence was limited to small studies and a few randomized controlled trials, but a seemingly acceptable meta-analysis of these trials supported these recommendations. So comparing the recommendations and guidelines to what I experienced in my own clinical practicum, I found that we generally within guidelines. In a nursing home, testing is often kept to a minimum due to cost and the patient family wishes. Cultures for blood or sputum are never done. The nursing home is strongly in favor of viral testing by rapid testing swabs. This has come from the days of the recent pandemic. In fact, nursing homes were probably one of the first places to use COVID and flu swabs religiously. If a virus is caught soon enough, antiviral therapy for influenza or SARS-CoV-2 would be initiated as concurrent treatment to antibiotics. And again, it's not respiratory virus season right now, so I haven't been able to witness that. So that's more or less just a guess of what I would see and what my preceptor has told me. I was not aware of the clinical prognosis judgment tool, the PSI. I can't say for sure if my preceptor was mindful of it and had used it without me knowing, but I suspect she's practicing solely on her 13 years of experience and trusting her clinical observations. I was impressed to see this, so I believe I certainly will remember to check for medical calculators for each diagnostic process. I played around on MedCalc after seeing that and thought that was really neat stuff. And as far as the last question, lastly, we followed the antibiotic prescription guidelines listed in the article. They seem pretty cut and dry, and I don't know that they've changed a whole lot in a long time. We had a few patients who had community-acquired pneumonia, and we prescribed a combination of Augmentin and azithromycin for one resident that I remember, and for another, one of our more sicker, and though we were sort of on the fence about whether to send her to the hospital, she had suspicion of a possible resistant organism too. She had been to the hospital, came back to us, and about 3 weeks later got sick. We did start her on Levaquin. It's not one of my preceptor's favorite meds to use because it can be pretty heavy hitting, but in this case that was appropriate, she thought. Anyhow, so this concludes my presentation for tonight. Thank you very much.